Ladies and gentlemen, welcome to this week's episode of What the Health Just Happened, where we talk about all things healthcare, community, business, and life. The goods, the bads, the ups, the downs, the lefts, the rights, and everything in between. We're lucky to bring on a variety of guests to bring their perspective on what they find to be healthy or not healthy and all the previous topics. Today's guest, I'm excited. Like I'm doing the radio voice now and I'm talking with my hands and doing all that stuff. For those of you who can't see it on the camera, we chatted for 15, 20 minutes earlier. CEO of Curative. I know what Curative is. Trey, you know what Curative is?
I know a little bit more about it.
You do now. Fred Turner, welcome to What the Health Just Happens. You ready? You ready to have a good time?
Let's go.
Or at least educate some people, and if we don't make you laugh here and there. So before we started the radio show, we talked about what brought you to the States. You were professionally milking cows, right?
Yep.
DNA sequencing, by the way. That's a terrible portion for sure. Pivoted multiple times. Let's pick up there. So Curative was doing COVID testing, PCR testing specifically. That was after doing septic DNA sequencing tests that did not work out. Let me know if I'm butchering this. So tell me, when did we pivot to PCR testing?
Yeah, well, it was meant to be a temporary pivot. We thought we would come back to sepsis. We thought COVID will last a couple of weeks. It'll be over. We're just going to help out, and then we'll go back to our sepsis testing. So we thought it was going to be temporary. At the beginning, when we hired people, we told them, yeah, this is a 6-week gig. Like, this is going to be over. We're hiring you to do this to support the pandemic effort, and then it'll be done.
Who are you hiring? Like nurses to administer tests, people to read the tests?
Mostly lab techs.
So you're hiring people, 6-week contract. We're going to run these tests.
So we thought it would be over and we just go back to sepsis testing. Like it took a while before, like, I guess we're never getting back to sepsis. I think by the summer of 2020, we were like, oh, this will be done soon. This
6 more weeks. Yeah, 6 more weeks.
We're going to get the vaccine. It'll be done.
So how long did that? And again, let's talk about the scaling up component, because you said you started with 7 people at Curative.
7 people at the beginning. Kind of February 2020, and then over the first 12 months, we grew to 7,000 employees.
You hear that, right? Yeah. So 7 employees in February 2020 to 7,000 12 months later.
Yeah.
That is madness. So what's your role in scaling this up? Are you getting new contracts to do the testing? Are you hiring? Are you filling seats? I mean, that's insane.
Just everything. I mean, it's bringing in a lot of great talent, right? Particularly on the recruiting side, building out the executive team to be able to manage that, bringing in like the best scientists. We hired a lot of ex-military. So our COO was a colonel in the Army for about 30 years before Curative. And so, great thing about what they teach in the military is how to do operations at scale across wide geographies very efficiently.
That is smart.
So you get, the best operators, you put them with the best scientists. We also hired a bunch of like Silicon Valley tech people, and you get everybody together and you get them all speaking the same language. That's where the magic comes from.
The people from Silicon Valley, were those previous relationships?
Yes. From
the Y Combinator days?
Yeah, there's 2 guys who were in the same YC batch as me. They were doing another company at the time, and they'd moved on to doing another company, and
Are they still with Curative?
No, they're not.
Okay, so we won't give them a shout out. You guys sold us out. I'm kidding.
They were instrumental in...
of course.
Yeah.
Well, again, it blows my mind. I don't even want to do the math. How many employees a month is that? What's 7,000 divided by 12?
And you did that in the midst of COVID too? Yeah. That's wild, because I wouldn't imagine most companies growing like that during COVID.
Well, and they were all over as well. It was all over the U.S.
How many states were you in?
We operated by the end in 49 states, everywhere apart from Hawaii.
So from day one, you're in California this time, right?
Yeah, so Curative actually started in Menlo Park, but we ended up moving down to LA. We acquired a lab in LA that became our first COVID testing lab. And then we built a lab in Washington, D.C., and then one in Austin, Texas.
So as you're doing these tests, you're flying the test to those separate labs, getting the results that then are reported back to 49 states. Again, just logistically and mathematically, it blows my mind. So exploding in what could be considered one of the most unique times in the history of the world.
Yeah.
People how are we going to keep our lights on? Is our business going to survive? Restaurants are closed. What state are you in? Who's the governor of the state? Still got to turn and burn these tests. So I think at one point you said you were essentially attached to 10% of all COVID testing in the United States. Is there a number on that?
It's about 36 million tests.
36 million
36 million, yeah.
PCR tests. How are you, I don't know this. How are you compensated for that? Is it insurance companies? You're negotiating with them to pay for the tests?
Yeah, it's a whole mix. A lot of it was direct contracts with states, cities, counties, various government entities that wanted to set up testing sites, and they would just contract and buy them directly from us. Then there was a mix of insurance companies, public and private, and then there was a fund for uninsured people to be able to get tested.
And then, are you negotiating these? Is your team, who's out there hunting and gathering contracts and adding a new state?
Me in the early days, but it quickly became the team.
You say it was you in the early days. How many trips did you start having to take to DC? Do you have to lobby for a lot of this stuff? Or are lobbyists involved in this portion or no?
There's some local lobbying.
Okay.
But not a whole lot of DC lobbying, no.
Okay. I didn't know if that was a roadblock to some of the stuff that you're trying to do.
No, most of the policy decisions were made pretty early, kind of in March of 2020, or at the CARES Act, and Families First passed. And they were pretty well-written bills. There wasn't a whole lot to kind of lobby for.
Gotcha. Fair enough.
We're going to talk about lobbying in a second, too. Hopefully. Are you going to end up being a political man or not?
No.
Okay. Yeah, run for the fences. Okay, so, again, explosion in a time where other businesses are turning the lights off and cutting back. As you grew, you're negotiating with insurance carriers. You're finding frustrations with the American healthcare system, I guess, learning the bureaucracy and, hoops you got to jump through.
Right.
But you also have a massive company, and you're probably looking for employee benefits for those people.
Yes.
Is that, I'm just
we could
laying up a canvas here.
Right. We could never get benefits that we liked. Particularly, I'm British originally, right? So I'm used to healthcare where it's $0 out of pocket. You just go get care. It doesn't cost you anything. We could never get healthcare that we thought was good. So we had a mix of Kaiser and Blue Shield of California. I'm a big fan of Kaiser. I think Kaiser is one of the best run healthcare systems in the US. But it doesn't work for everybody. You can't just offer Kaiser. Some people love it, but some people hate it. They haven't solved that, how do we be a full replacement product? And then Blue Shield of California was just dreadful.
What was dreadful?
Very hard to work with, no flexibility. They insisted it was impossible to have a deductible less than $500.
Is this from a executive? Again, this is a rhetorical question. I've got my own thoughts and answer. Is this from an executive perspective, where you're frustrated the cost coming out of the business, or are you frustrated on your employees' behalf?
Both.
Yeah.
But we have things where it's we're running at 72% loss ratio, and they're saying that we need a 35% renewal. And it's well,
do you understand what that means?
I kind of do, but if you wanted to explain it, because I imagine most of our listeners have no idea.
Yeah, it's nice sometimes to fill in the gaps.
Yeah, so 72% loss ratio means we pay them $100 of premium, they spend $72 on medical bills. They keep the other $28. But they turn around at the end of the year and say, well, actually, now you need to pay me $135 next year. It's well, if you only have $72 of medical bills, what do you need an extra $35 for? It seems like you're making a lot of money out of us.
I have my own theory on the medical loss ratio, right? So let's say for every dollar spent for large carrier, I got to be careful what names I say, they keep 80 cents of that. So what's more money, 80 cents of a dollar or $80 of $100? They have to spend $80 of that, 80% of that amount. I'm butchering this. I think you get what I'm saying.
Right.
So why would they not raise the cost? Because that difference, that spread is significantly higher when you raise the cost. Sometimes I try to explain things to Trey, even though I'm butchering it.
Yeah, it's one of the, I guess, the most backfiring provisions in the Affordable Care Act is there's a cap on MLR. So if you, as a large group insurer, run below 85% medical loss ratio, so you don't spend at least 85% of your premium on claims, or it's 80% for a small group and the individual market, then you have to rebate it. You have to give it back to the group at the end of the year. Now, it's at an aggregate level. It's not for an individual employer. It's across your entire business. But the incentive that drives is, well, if I can't make more than 15% by profit by being efficient. The only way to make more money is to spend more on healthcare, which is just the wrong incentive structure. Look, this is gold to me.
Hearing you say that, that's great.
It's frustrating, and if you don't,
it's one of those ideas that like sounds like a good idea. You can see why they thought, oh, if we cap insurance,
it was a good intention.
Then this will help with restricting healthcare costs, but it's not the right incentive structure.
How many times have you heard people say healthcare is broken in the U.S.?
Just constantly.
I don't. Let me tell you what. I don't like that saying because I don't think healthcare is broken. I think it's working exactly how it's designed. Yeah. So how do you redesign something new? The smartest man in the room right here. So yeah, you're dealing with these frustrations for your business personally, and then what happens? The light bulb goes off, or you're just sitting in a room drinking a coffee and said, "I'm doing this."
It was a bit more deliberate than that. We call it Curative 1.0. It's a testing business, and we're like, oh, well, what happens next? Because remember, we thought it was going to end
in 6 weeks.
In 6 weeks, so we're thinking like, okay, well, do we go back to sepsis? What do we do? We looked at a few other things in the lab testing space. We looked at this really interesting technology where you could, instead of ordering a lab test for this, a lab test for that, everything would be one test, and then one test would test for everything, and then you would just pick out what you wanted. The science wasn't really there, so we didn't move forward with that. Briefly looked at buying a hospital and trying to see if we could make it better with tech.
What area?
We were looking in Texas primarily, but we looked at a few in Florida as well. This is basically what General Catalyst is trying to do now with their acquisition of Suma Health.
Okay.
And we decided it was a bad idea, so I'm really curious to see how that goes.
You're going to follow it closely? Oh, man.
It's just very hard. And if you buy one health system, you only impact the health in that one very specific area. There's probably another system that you're competing with. Most employers just have employee populations that are too spread out for that to really be impactful. And so we decided our main wasn't going to work to drive the impact. And everything we looked at on a preventative healthcare side, we basically realized you're either chasing a billing code that already exists and just trying to do more of it, or maybe be more efficient. And is that really helping? Are you really helping the system? Or if you have something genuinely new, you have basically a 10-year fight with insurance companies to get a CPT code, get it covered, get a national coverage determination.
So you know what a CPT code is?
I do not.
Again, I love sometimes just jumping in for whoever happens to hear this.
Yeah.
You go to a doctor, you have your belly button hurts. They're going to put in a CPT code for that, diagnosing belly button pain. Again, it's more complicated than that. That CPT code will determine what your insurance reimburses and why.
Interesting.
Again, very simplified version of
everything. Gotcha.
And if it's typed in wrong, you're going to get billed more. If it's not typed in at all, your insurance isn't going to cover for a procedure.
So if you have a new thing, it doesn't have a CPT code, so you can't bill because there's nothing to bill. You don't.
And what is the time frame you just said for that to start?
Years.
So you can get a new CPT code arguably within 2 years if you know what you're doing, but then no one's going to pay for it. So getting a code, getting the coverage determination, getting payers on board, actually getting paid, it's 5 to 10 years generally.
Are you learning this as you're starting, growing Curative, and you're figuring this stuff out, or you decided we're to do Curative 2.0?
Similar with a brand new test at my last company at Shield. We could never get anywhere with, even though it was saving the insurance companies money, they just getting that coverage is very challenging. So we decided that the problem with lack of preventative health is really that health plans are just not currently set up to actually drive engagement in prevention. And although there's a lot of talk about wellness, it's just talk. It's not real, and the plans are not designed to actually drive any meaningful outcomes. They just talk about wellness because it sounds good. And so we wanted
shiny object.
Yeah, we wanted to build a plan design that actually does it. That's why I kind of hate the word wellness.
I'll openly talk about this with you too. I feel bad because we have some relationships and friends in our community that work in the wellness space, and they all have good intention, but that doesn't move the needle, in my opinion. I'm sorry.
Right.
So no deductibles, no copays, no really. I love that tagline.
Yep.
Why? How? I mean, it's just saying that. I'm like, that doesn't sound like that's not a real thing.
So as we dug in, one of the things that we really honed in on is like, what is stopping people from getting access to preventative care? Like, why don't people go and engage with healthcare early before there are problems and deal with it? Some of it's just human psychology, but some of it is like the barriers that we've put in place, right? So there's an administrative barrier that we have prior authorization, and we make everything like more complicated than it needs to be. But there's also this financial barrier where we've moved towards this system where we try to charge you every time you go do something, even if that thing is like incredibly beneficial to the insurance company because it keeps you out of the hospital. We still try to charge you under the idea that maybe if you didn't really need it, you wouldn't bother. But it just is like, it isn't real. It doesn't really
It's friction
work like
points.
that. Right.
And financially damaging friction points.
Yeah. So all it tends to do is drives this pattern of care deferral, but it isn't like sensible care deferral. It isn't people pushing off the right things. It's people just pushing off everything. And there's a lot of data out there that shows actually the people who most need care are the ones who tend to defer it the most because of their out-of-pocket cost. The ones who didn't really need it find a way to still go and do it anyway. So you're not saving the right kind of care. There's a really good study that we talk about a lot that the National Bureau of Economic Research did in about 2015, and they followed this group of about 50,000 members that moved from no out-of-pocket cost to a high deductible plan, and they follow what happens. And in the first year, you get about a 12% reduction in claims cost. And so it looks like, okay, we've given people this high deductible plan. They must be out there price shopping. They must be looking for the most affordable options. They must be avoiding unnecessary care. Problem is, when you like dig in and look at what's actually going on, the hospitalizations stay completely flat. The specialty drug expense actually goes up. All of that 12% saving comes from people, they don't go get their primary care visit, they don't get their checkups, they don't get their colonoscopy, they don't get their mammogram, all the stuff you really want them to do.
The proactive care versus reactive care.
Downstream, they just stop.
What year was that report?
That was 2015. Like, we've known about this for a while, but there hasn't been a whole lot of action. So people just kind of defer care, and it's even like in kind of illogical ways. So in that study, colonoscopies would still have been free because it's a preventative service under ACA. Even with the deductible, it would have still been $0 out of pocket. But they go down by a third in that first year. Because when you tell people, hey, you have a deductible, it's going to cost you money to seek care, they don't read the benefit booklet. They don't know the details.
Hey, guilty.
What does my EOB say?
So that's great. So they just think, okay, I shouldn't get care. I should avoid it. I don't need the colonoscopy. I feel like I don't have colon cancer. And that's the behavior you get. And so by the second year,
You're like, man, I probably need a colonoscopy.
you're basically already back at baseline costs by the second year. And by the third year, your costs have gone way up above what you would have expected them to be. And over a 3-year period, you end up spending about 8% more. So, and then this short-term saving
Early on, you're seeing a 12% dip.
right? But then you
For a variety of reasons that's really not good news. And then over the long
over
term,
a 3-year, you spend 8% more because all of that deferred care catches up with you, right? You actually can see a measurable increase in colon cancer by the third year because you're not doing colonoscopies. All of your primary care checkups that could have been your pre-diabetes, hypertension, getting it managed, getting people on medication, they skip it and then they end up in the emergency room with a diabetic ulcer or a hypertensive crisis. And now you've got a $100,000 hospital stay that you didn't need, that was totally unnecessary.
Would you say men are even more susceptible? Like they're probably the ones that are falling into this category the most, or are women just as guilty in regards to just like avoiding the care?
Yeah, we definitely see it's like men in their 40s and 50s.
What?
Yeah. Worse, because they're like getting out of that phase of like, oh, I don't need to see doctors. Like, no, you really do need to see a doctor every year. There's some things you need to do, and the deferral is crazy.
Oh, I'm guilty of it. I'm about to be 40.
Up here, I'm still in my 20s, but everywhere else, I'm 41.
Exactly.
Right. Yeah. You definitely see that.
So back, and again, so Curative, would you call this now 2.0 or are you on version 3.0?
2.0.
We're on 2.0 now.
So yeah, so I can talk a bit more about our model and how we
I think we just hammer this in. What groups is it for? Like the pharmacy side? Yeah, go ahead.
Yeah, so we have a very different approach to this. We think cost sharing is the enemy. So the Curative plan, no copay, no deductible, no coinsurance. Everybody has $0 out-of-pocket cost for any in-network care for the first 120 days. And
Say that one more time.
So for the first 120 days, all in-network care is completely free. You can go see your PCP, you can have a baby, you can get cancer care.
Really?
It'll be $0.
Have a baby?
I had a $0 baby in January.
Yeah, funny. My wife listened to that. We're going to have a fourth. Dang it.
Oh, man.
3 is good.
It was pretty great. And then you have a 120-day window. During that 120 days, you have to complete what we call a baseline visit.
This is very important component to acknowledge.
Yeah. It's basically it's like a 1-hour Zoom call. It's with our staff. It's 30 minutes with your care navigator where they're looking to onboard you to the health plan. So they explain, what is a copay? What is a deductible? What does a network mean? What is out of network? Like, let's check that your drugs are on the formulary. Are you going to an in-network pharmacy? They explain all of these complex healthcare words that most people just don't know what they mean.
Yeah.
So you actually understand how to use your health plan. And then the second 30 minutes is with a clinician, really looking for gaps in care. So they're
RN, physician, PA, what level clinic?
it's either an MD or a nurse practitioner.
Okay.
Yeah. So they have prescribing authority.
Yep.
They can, if you're, know you should be taking a medication you haven't filled in a few years, they can write you a prescription for it. Really looking for gaps in care, looking for people who sort of know that someone told them they're pre-diabetic, but I don't want to see a doctor because it'll cost me $20 and then they'll prescribe me something that'll cost me $50. I feel fine. I'm just going to leave it like that. We see so much of that. And we can get those people and say, look, we're going to get you into a PCP. It'll cost $0. We'll even make the appointment for you. All you have to do is show up. They're going to prescribe this drug. It'll cost $0. And by the way, we'll deliver it to your house. All you have to do is take it.
It's wild.
Okay.
And you get more of that engagement. So if you don't do the baseline visit within the first 120 days, on day 121, you revert back to a $5,000 deductible and 20% co-insurance.
So this is good because we had about 2 minutes to the commercial break, and then we'll hit more about this. Man, we're going to run out of time so much. The model that most people are used to, right? High deductible. What was the co-insurance?
20%.
20%. If you do this baseline visit, 0 copay, 0 deductible.
Yeah.
So are you going to be incentivized to actually do that?
Absolutely.
And that was my skepticism. Like, wait, how many people are actually going to do this?
Well, you get 98% of members complete the baseline visit.
98% of people complete the baseline visit. And what do you say on our prep call? The 2% that don't?
It's a good predictor for HR teams of who is interviewing at other companies.
That is
Didn't
good.
even think about that.
That is good. And then one more thing here too. So for groups specifically, it has to be 50 employees or more and at least 25 enrolled.
51 eligible employees or more, 25 minimum enrolled.
51 eligible employees, 25 enrolled. What I can guarantee happens is if you have 51 eligible and you only have 18 participants, that number is going to jump up to 30 or 40.
Yeah.
Man, great first half. I knew that would fly by. CEO of Curative, Fred Turner, congratulations.
Thank you.
On the newborn, by the way, and a really awesome business. That's what the hell just happened. Welcome back to the second half of What the Hell Just Happened. If you missed the first half here on the radio show, good news is it's available on your favorite podcast platform under What the Health Just Happened. Today we have, again, great guest. I don't know how we fumbled upon this. We're actually filming this in Orlando versus Jacksonville normally. CEO of Curative, Fred Turner. Great story. How did it start? Where you came from? That was off the air. Curative, man. We're going to get to that in a second. We got to talk about the zero card, 0 deductibles, 0 copay, no deductibles, no copay, no really. That's the tagline. No deductibles, no copay, no really. I love saying that. We like to play a game called Healthy or Not Healthy, right? We got our cheesy hats here, which you're going to get one of these.
All right.
And if you're feeling healthy, you just pop the broom like that. Hashtag healthy. But healthy or not healthy, calling football soccer.
Oh, not healthy.
Healthy or not healthy, American football.
Oh, I think I'd have to say healthy. I've been here long enough now.
Healthy or not.
Offend people if I say not healthy.
You can offend people. We all offend somebody. You're definitely offending large insurance carriers right now. Healthy or not healthy, prior authorizations.
It depends on the fence.
Oh, if you were leaning towards one way, what would you say?
They're like a necessary evil. Unhealthy, but they are required in circumstances.
Healthy or not healthy, CPT codes.
No, healthy.
Healthy or not healthy, the first 5 months of sleep with a newborn.
No, healthy.
You got any you want to throw in?
No, that was a good one.
Kelly, you got any you want to throw in? My goal is when people leave, they start texting and saying randomly all the time, healthy or not healthy. Seriously though, I got half free, but also healthy or not healthy. Guinness beer. Healthy?
Definitely healthy.
Okay. Well, you can take that or not. We picked that up on the way over here. Let's get back to business here. Oh, also thank you 212 for sponsoring the show. That's our company. We are very bullish on Curative right now. So no copays, no deductibles, no really.
Yeah.
Talked about how it started. Let's talk about the data, right? The information you had, how you can show success when people are like, how is this possible? How can you sustain this? How are you making money?
Yeah. The biggest question we get is, don't people just go to the doctor all the time? Aren't people just using all the healthcare? There's a couple of things. One thing we found is that like people actually have better things to do than go to the doctor all day long. Like it's not actually what they're, super excited to do. So you don't see that massive uptick in utilization. But the other thing we see is on the hospital side, by getting our members to actually engage earlier, go and manage their conditions, take their medications. We have 95% med adherence for type 2 diabetes, 93% for hypertension. So this is people with those conditions, 95 and 93% actually take their medications as they're supposed to. And national numbers are more like 70%.
That's what I'll say. So the national average for those same diagnoses is 70 to 75.
Yeah. If you don't charge people $10 every time they pick up their prescription, they actually do it. We do same-day delivery, so we drop it off at their house. We make it super easy for them, so people actually take their meds. This lets us keep people out of the hospital. So we see about a 30% lower rate of hospitalizations compared to kind of best-case national average data.
How long has this existed, right? You said you have 3 years of information so far?
About 2 years.
So 2 years so far.
Yeah.
And you're taking what's arguably the best statistics nationwide, and you're performing better than that.
30% better.
And you have evidence to show people this. Like for personally, so 212 Benefits, we talked to a 100 life group. They're sitting at 50 enrolled employees. Like, how are you presenting this to groups? Well, if you have a mic on.
Like, we show them the data. We will show you the data of hospitalizations across our groups. Like within just 6 months on the plan, we can see this measurable decrease in inpatient hospitalization rate. Getting people engaged in their healthcare early, and none of it, it's all like really basic stuff, right? It's like take your medication, see a doctor, do your screening test, do your blood work. But it's getting all of that stuff done across 98% of your population. Like we know this stuff works. We know if you take your medication, have a PCP. Like there are countless studies. It's not rocket science. We know what works to keep you healthy. It's just how do you get it done across your entire group? And so that's where the 98% engagement we get with the baseline visit, getting everybody in and through that, we're able to drive a lot more of these behaviors. Where for a traditional health plan, if you're getting 20% of your members to engage in any kind of like program, disease management program, that's considered really good. And we're getting 98%. So the members that are most difficult, we get them through.
I have so many thoughts. I did think of one thing. Trey, when was the last time you saw a PCP, primary care physician?
10 years ago.
When was the last time you got blood work?
Probably 10, I don't know, high school.
I like Trey's honest. That's the majority.
I'm probably
why is it? It's because of I don't want to pay the
call like little tiny nudges. I had also not seen a PCP in about 6 years before I did my Curative baseline visit. You got me set up with a PCP. The other thing that I had never done is skin check, like a
dermatology.
Because in England, it's like not really a thing.
There's no sun.
No sun. Yeah. So it's like, you probably don't have skin cancer because there's nothing, there's no UV. It's just rain. So I'd never had one because it just was not a thing that like we did growing up or you heard about people doing. And they were like, you live in Texas now. You might want to do that as you're like super pale. Yeah. you got to get this done like once a year. And so I went and had it done, and they removed a little mole here, and it came out. It was precancerous.
Oh, really?
Yeah. So if I hadn't
see a dermatologist,
hadn't had that done, like I would have not, you would have never bothered. But my care navigator made the appointment. I got it all set up. It didn't cost me $1.
So you're actively using like what's you remember the old Rogaine commercials or the hair loss commercials? Not only am I the doctor, but I'm also a client. Like you have actual evidence of using this because you're using it yourself.
Yeah.
Which again, I think that was a really cool story. You had a baby that was
a $0 baby was pretty great.
That sounds. I'm sure there's a lot of people that would be banging on the door for that.
Yeah.
I have to ask this: why Like, why haven't the large carriers tried to do this?
So it's really hard because it only works if you're all in. So the 0-0, it only works if you offer it across the board. If you try to offer a $0 plan alongside a high deductible plan, it doesn't work because all of your young, healthy people pick the high deductible plan, continue deferring care and never seeing a doctor.
Yeah.
And then they get sick. Now they want to come on the $0 plan. So you're still not managing people. It only works if you go all in on everybody get 0-0. And the large carriers have spent the last 20 years telling people that high deductible plans are the solution. We just need more consumerism and it will all be fine. Like, how's that going? Not good. Not very well. So it's kind of hard to pivot and say, Ashley, you know what? We were wrong for the last 20 years. Deductibles might not be the solution. You should entirely throw them away. That's a pretty drastic line for a large health insurance company.
Do you get dirty looks or emails from large carriers?
We definitely get dirty looks at road shows and industry events.
Those curative folks.
Hey, you wouldn't get them if you weren't doing something right.
Yeah.
Do you know what I mean?
Yeah, that's the truth. Okay, so current states that your Curative's available.
So we are available to employers that are headquartered in Texas or Florida.
So headquartered in Texas or Florida. That's important to note.
Soon to be Georgia.
Soon to be Georgia. Look, if you're going to work with someone in Florida, I'd recommend 212 Benefits or Georgia. We can work there too. I got some great agencies in Texas, by the way. I'm kidding, obviously.
We can cover people anywhere there. So we have members across all 50 states. We have people in Alaska. We have people in Hawaii.
But the headquarters has to be in which is typical. And again, forgive my shameless plug. I'm not serious. If you're a business and you want to consider this, it's good for your business, then consider this whoever you work with.
Why are they typically based in Florida and Texas?
That's just, you can answer.
It's just how the insurance licensing works.
Fair enough.
It's wherever the transaction happens. So we are licensed to transact insurance in Texas and Florida.
Gotcha.
Because the deal has to happen there.
Okay.
So we have a couple companies that are headquartered in Florida, and 80% of their employees are in different states. However, the plan is based out of Florida. That's just how our...
Right. So that's partly why we picked Texas and Florida as our... There's a lot of companies that have their headquarters set up here, moved their headquarters here, particularly, through COVID over the last few years. There's a lot of companies that have moved. And it doesn't matter where their employees are. So we cover a lot of California members, we cover New York members, but as long as they're one corporate employer, that's Texas or Florida.
Again, I laugh how many people have ended up in Texas and Florida, and I think this is a big reason. Just right, there's a bunch of reasons. We won't go down that road. Just try to get all fired up over there. Let's talk drugs. Do you like drugs? I'm kidding. Like pharmacy drugs. I always like to vote out a drug. How does the pharmacy side work? Again, a whole conversation about PBMs. That whole system will explode minds.
Yeah.
How are you doing the pharmacy side? How are you guys dealing legal drugs?
So we have it set up, again, really focused on the $0 out-of-pocket cost. So for every disease you might have, there is an option available at $0. So if you have a condition where the only drug available to treat it and you need it or you'll die is a super expensive brand name specialty medication that's $500,000 a year, it'll be $0 out-of-pocket. Because there's no point charging people $100 a month. It doesn't help pay for the $500,000 the medication costs. All it does is mean they're less likely to, I won't bother taking it this month. And then you're going to be paying for a $100,000 hospital stay and the drug next month. So we want to avoid that. We want people to take the medications. However, if in a given category of drug, there's two options, one's a generic, one's a brand, or one's a biosimilar, and one's a brand. Biosimilar is kind of like a generic for biologic drugs. We will have picked the most cost-effective option, and that will be available at $0.
Love it.
Yeah. Again, so sometimes it's helpful for me to say this out loud too, because I'm like, man, this just seems wild to me. So company X has an employee that has access to two different medications. The one that's biosimilar or generic will be $0. If you want the name brand, which again, they're the same exact medication, just a different stamp on the outside label, you will have to pay an additional
$50 or $250 copay. And so the key example here, I think, like Humira is
Humira, that's a great,
really good example. So
very expensive medication.
It's $6,500 a month, but it comes with a $2,000 a month rebate. So you're the PBM is making $2,000 a month every time they fill a Humira script.
Cha-ching. Guess what you see commercials for all the time?
Oh, yeah. It went off patent last year in February. And so now there's a biosimilar, and the biosimilars are priced as low as $500 a month, but they don't have a rebate. So the PBM doesn't make any money when you fill one of those. So most of the national plans are still pushing people towards Humira, or at least they're not, preferentially driving them towards the biosimilar, because even though it's $4,000 a month more for the employer, they'd rather get their $2,000 rebate. So February 1st last year, there were only 2 plans in the country that kicked Humira fully off formulary. It's just not covered. We'll only cover the biosimilar. It was us and Kaiser Permanente.
Man,
Aetna finally got around to it this year. Several of the other plans still cover both. So it's like, well, you can have the Humira or the biosimilar and they're covered the same. But they're not driving people towards the biosimilar, which is really what they should be doing.
I'm trying to think if there's some medications. Every client or group we look at, Humira's on that list.
Right.
I'm going to draw a blank on medications now. The card, the Curative credit card, I call it. Zero card. So again, this is in our space. Trey's over there. I love when Trey joins because he's like, I have no idea what these guys are talking about. But a lot of people listening will understand this. Incredible stuff going on. Frequently asked questions, flaws. I go to a doctor. I walk in there and I say, I need to get my ear looked at. Yeah. Well, we don't take this. We don't know what this is. We've never heard of Curative.
Yeah.
What happens?
Yeah, so this was definitely a challenge that we faced. We initially tried to tackle it by just calling every provider in the country and trying to educate them. That's a little challenging. There are quite a lot of them, and the front desk people tend to turn over pretty quickly. So we kept hitting this problem. The solution we built, we call it the Curative Zero card. It's a credit card, a Visa credit card. It's issued in your name. I was going to show you that this is a card buried too deep in my pocket with all the microphone.
Sorry.
It's a little black Visa card issued in your name but funded by us. And if you're ever at the provider office and they say, oh, we don't take that, you just say, okay, I'll pay the cash price, tap the card, you're done.
Is it always active, the card?
Yeah, so it is always active.
Is there ever foul play?
It'll only work at in-network providers.
Okay.
You won't be able to use it to buy your groceries.
Yeah, I'm saying, is there going to be someone out there like, I'm going to go buy a 6-pack of Guinness? And
no, it'll only work at providers, and there are limits, there's dollar limits.
Yeah.
Given whatever the provider type is, if you try to spend far more than if you have a $20,000 PCP visit, it'll decline.
But again, this is to reinforce how good this is for employers and employees.
Yeah.
All these friction points that people are accustomed to dealing with, death by paper cut, $20 here, $50 there, gone.
Yeah.
You go somewhere and they're not accepting it, friction point eliminated. Again, I'm just reinforcing this because
we want people to get care, right? We want as much access to care early because that's what saves us money on the hospital costs. So sometimes we have this problem where people want to bring their doctor into the network, but if doctors are really busy, they might not have a legal person, they might not have somebody who can sign a contract with the health plan because they've got a lot going on. And so we can't always contract with any given provider, even if we want to, just because it's hard to get it done. But we can let you go there on the Zero card and just accept their cash price. And we found that those are actually often better than the contracted rate anyway.
Gosh, that's a whole topic there.
Well, because it's easier for the provider. They don't have to bill an insurance company. They don't have to deal with audits. They get the money up front. They know that they're getting paid and they're done. And so we can expand the access members have, let them go to providers that they want to go to on the Zero card.
Again, Trey's like, I don't know what you're talking about.
No, I mean, my wife would be happy having that. Take her stress levels down when she's having to go to the doctor. And
this is
that fear that you're always going to get seen because maybe they don't know that they take Curative, maybe they don't know that they take First Health. Definitely know that they take Visa.
Yeah.
That's it. There's another tax.
True, yeah.
We're so excited about this because as an employer, this is great. But I always, my concern is always, and frustration is the end consumer, right? Yeah. His wife, my kids are too young. But the people who don't work in this industry and don't know how to play the game, and even we sometimes we're like, what game is this? It's like playing a three level chessboard with water as your pieces, right? Let's go back to pharmacy for a second. I know in Florida there's a relationship with Publix.
Yes.
Why Publix? And then if you don't use Publix, there's also a mailing option.
Yeah, so at the Curative Pharmacy available, we have one in Tampa, one in Fort Lauderdale. We'll do free same-day delivery within a 30-mile radius or pre-next-day delivery anywhere in the state. We want to make it really easy to get your medications. However, we have found that we can get better rates for the same drug through either using the Curative Pharmacy or through Publix. So excluding CVS and Walgreens, we're able to save about 8.5% on film cost.
That's a lot.
Same drug.
Adds up quick.
8.5% more if you buy it from CVS.
And who doesn't want to go to Publix either?
I think they're building Publix is building a pharmacy distribution center in Northeast Florida. Have you heard about that? I got to look that up. I think it's St. Johns County, just south of Jacksonville.
Okay.
So again, if you're in the Fort Lauderdale area, Miami area,
cover basically all of South Florida with that.
and then Tampa area, and as you expand and see what markets look like, we're currently sitting in Orlando. We happen to be in Jacksonville.
Yeah.
Who knows what happens? But worst case scenario, you got Publix, and then there are overnight deliveries.
Yeah, in Texas, we have one in Austin that does Austin and San Antonio, one in Houston, and one in DFW. So we'll add the other metro areas in Florida in time.
Any big things I'm missing? Because I got kind of two loaded questions here, but I want to make sure they're like, I got to talk about this.
I think we pretty much got everything.
It's hard to cram years of efforts, and this is a game changer.
I guess we are AM Best, A- rated.
Say that again.
We were A- rated by AM Best.
Do you know what that means?
I mean, I imagine it's like 4-star. What was it? The last guy was rating star. Is it like you guys are 4-star, or is it out of what, A-?
So it's the financial ratings. It's not really about like the plan and the quality of the plan. It's about the financial stability of the company. So you have the money to keep going. Basically anything that's A-, the technical description is excellent.
Okay.
For that. So most of the large carriers are A- or B+.
That's a big deal.
Yeah, it's hard to get.
What hurdles, what are some things that concern you in the future? Like, we're going to run into this barrier soon. Maybe there are not. But when you look down the road, you're like, this is going to be a problem coming up.
I don't know that it's a problem, but I think, the biggest thing we face is we work with employers who are fed up with the status quo and fed up with what they're getting, but they still want to keep buying Blue Cross. And they expect a different result when they're just doing the same thing. It's like,
sounds like politics.
Definition of insanity. Doing the same thing again and again and expecting a different result. If you want to get a different result, if you want to not have a 15, 20% renewal every year, if you want to not have unhappy employees because they're getting thousands of dollars of bills every time they go see a doctor, you have to be willing to try a different approach.
Yep.
And it's just getting through, to employers of like, hey, try something new if you're looking for a better performing plan.
We deal with that every single week, right? I'm so sick of this. This doesn't work. It's like, okay, here is a different solution, but you need buy-in from the top. I'm sure everyone on the bottom would be like, yes, let's do this.
Yeah.
And it takes effort, right? It takes buy-in's a huge one, but somebody has to manage it, hold your employees accountable to make sure they're doing those initial assessments, baseline. Sorry, I keep calling them initial assessments. I don't know if that'll ever change unless someone's pain point is just so much, but starting the conversations now is great.
Yeah.
Okay. So 1, 3, 5, 10 years, what are you excited for? This is going to be a healthy change for Curative.
Yeah. No, I mean, we want to grow into being a national plan, certainly on the 5-year time horizon, being in most states nationally is the plan. We think this is just a better way of doing healthcare, that this is the direction things have got to go. We can't just keep having ever increasing deductibles. It's not real health insurance.
Yeah. I would say this too, what industry or products can you get an 8% increase every single year and just be like, okay.
Well, no, I mean, people ask us oh, how is this sustainable? But you kind of have to turn that question around and be like, well, how is the current, okay, your deductible went from $7,000 to $7,900 and your rates are also going up 10%. How is that sustainable? Where is that going? After going to have $15,000 deductibles soon? Where's it going?
Anything else? You got anything else?
No, I just find it fascinating when you mentioned the way that this is able to work is everyone is all in, correct?
Yeah.
So everyone has skin in the game, which is the way it's able to succeed. But if you don't, it can't work, correct?
Yeah.
I like that.
Well, because the janitor is equally likely to have a heart attack and end up in the hospital as the CEO.
Sure.
You have to make that investment. It's going to cost the same amount, no matter who it is in the company. It also could be the dependents, right? You're looking at an employer. It's not just about getting your employees. It's also about getting their dependents to understand the health plan, to be taking the right actions and engaging. You've got to get everybody in. And that's why all adults have to do the baseline visit. Even the dependents have to do that baseline visit, because we need that level of engagement from everybody to make it work.
Any shout outs to anyone before we wrap it up? I always like, hi, Mom. I love you. Thanks for listening.
Well, hi, Mom. Shout out to my wife, Dina, and Lincoln.
Dina and Lincoln. Love it. New dad, too. We love dad banter, by the way. Congrats.
Thank you.
That's incredible. And you're traveling less.
Yes.
Other than you flew into Florida, then you're flying back to Austin today.
Yes.
What's the next trip?
Next trip is our summer vacation.
Good for you.
Yeah.
Good for you. Man, zero deductibles, no copays, no deductibles, no really. I keep saying zero. No deductibles, no copay, no really. I love that. Companies with 51 or more employees, minimum 25 enrolled. You're tired of the status quo. You're frustrated with how it goes. I cannot recommend Curative enough for a variety of reasons. I mean, it blows my mind. Thanks for joining. Did you enjoy yourself? At least a little bit.
Oh, yeah.
Right? If you're back in Florida, you come back on.
Definitely.
Next time we'll do it at a bar. We'll crack a Guinness mid-episode.
While watching football, not real football.
Real football, not American.
His football.
There we go.
That was great, man. Let me get a fist bump. That's what the hell just happened.